Hello everyone, we have started the preparation for our general surgery subject. These notes are made from the surgery book Bele and Love, the Abdul Wahab Dogger book, and some points from first aid book. We have already discussed all these topics. The last topic that we discussed was needle and sutures, diabetic ulcers, diabetic foot, venous ulcers, chronic leg ulcers, and wound. The shock and hemorrhage. These topics are already discussed in the first videos, which I am highlighting. Today we will be discussing the topic fluid and electrolyte. This one is our target today. Then we will discuss the surgical infections, and then the necrotizing fasciitis and cellulitis, and then carbuncle. So starting from fluid and electrolytes. Okay, this is our topic today. Okay, in this chapter we will just discuss that what fluids are or electrolytes are important at what cases, and what defects or diseases which type of electrolyte or fluid is required. So first we will learn that what is the requirement for adults and children, then what is the specific amount, and then which type of fluids are there. So the first one is what is the water requirement for the maintenance therapy. So in adults it is fixed. For adults in the maintenance therapy we will give 45 ml per kg per day of fluid. Okay, while in children it varies, we have to calculate it. The age in children varies, so the fluid given also varies. We will count that according to the weight. So for first 10 kg we will give the 4 ml per kg per hour. This is the fixed fluid for first 10 kg. For example, if a child comes with the age of weight of 10 kg, then we will give the 4 ml per kg per hour the fluid. Okay, now for the next 10 kg we will give the 2 ml per kg per hour, and for the each kg above 20 kg we will give 1 ml fluid per kg per hour. For example, if we have a child and its weight is 25 kg, then for the 10 kg the fixed fluid is 4 ml per kg. Then the in 25 10 is minus, then 15 left. So the next in the 15, the next 10, the fluid for the next 10 will be 2 ml per kg, and the 5 then remains. Then the 5 is about 20 kg. 20 kg is calculated, that is for the first 10 kg it is 4 ml, for the next 10 kg it is 2 ml, so 6 ml for 20 kg. Then 5 kg is left, so the 5 kg are above the 20 kg, and above the 20 kg for each kg weight the fluid required is 1 ml. So for 5 kgs about 20, the fluid required will be 1 ml per kg per hour. So this is discussed here. First 10 kg 4 ml per hour, second kg 2 ml per hour, or for next 5 kg it is 1 ml per kg per hour. So the 4 ml per kg per hour or 40 ml per hour, 2 ml per kg per hour or 20 ml per hour. Simply you can do that. Just multiply the number for 10 kgs, that is 4 with the 10, and that is the amount of fluid required per hour. So the total fluid that we require for 25 kg baby is 40 plus 20 plus 5 is 65 ml per hour, or simply we can say that 65 multiplied by 10 is equal to 800 ml per day. Okay, so this is the total amount of fluid that is required. What is written here? Abdominal pain, nausea, vomiting, and severe dehydration. Daily requirement of fluid for this child. Calculate fluid plus electrolyte and imbalance for 50-year-old lady with acute intestinal obstruction. So the questions like this can ask by the examiner that a patient is having abdominal pain and nausea and vomiting and some dehydration. So what will be the daily requirement of fluid for this child? So you have to calculate the weight of the child and simply apply this formula. So you will get the amount of fluid required. Now in this we have fluid and electrolyte balance of 50-year-old lady with acute intestinal obstruction. So for 50-year-old lady you have to calculate the fluid balance. Now what are the fluid therapies? We have parenteral fluid therapy. In this we have crystalloids. The crystalloids are normal saline, ringer lactates, and hypertonic saline 1.8% and 3%. Then we have colloids, for example proteins, branched polysaccharides, blood substitutes, for example albumin, dextrose, and gelatin. Then which fluids are present? We have for gastric outlet obstruction, vomit loss, sodium, hydrogen chloride, and potassium. So NaCl 0.9% is given as this sodium and chlorine is lost. In diarrhea, small gut secretions rich in HCO3. In diarrhea, what is lost? The small gut secretions, which is rich in HCO3. So, for this defect, ringer lactate is given. In sweating, there is acclimatized and non-acclimatized or inacclimatized oral fluid of 5% dextrose water is required, while in non-acclimatized normal saline or ringer lactate is required. For pancreatic fistula, HCO3 is lost, so 50 mm of sodium bicarbonate is given. In hemorrhage, blood is lost, so blood and colloids are given. During post-op, 5% dextrose water is given, and in intestinal obstruction, ideally linger lactate is given, plus extra potassium can also be given. As the question is asked here that there is intestinal obstruction in 50-year-old lady. So you know that in intestinal obstruction, ideally we give ringer lactate plus extra potassium. So you have to learn this, which type of fluids are given in what cases, and what is the composition of each fluid. For example, what is the composition of crystallites, and what is the composition of colloids, and in what defects. For example, in diarrhea we lost the small gut secretion, so a fluid is given to fulfill that. So for this purpose you have to learn the composition of all the fluids, and its doses, that in how much amount it is given in which cases according to the age and according to the maintenance therapy. Now coming towards surgical infection. Okay, so what is the definition of surgical infection? Infection at site of surgery that occurs within 30 days of surgery if there is no implant, hardware, artificial graft or mesh etc. left in place, or within 1 year if an implant is left in place and the infection appears to be related with operation. That infection is known as surgical infections. What questions are important in this topic? We have defined surgical site and infection. What are the risk factors, what are the types, and what are the treatment options? So in general infections, some general factors are involved and local factors are involved. In general factors we have age, obesity, malnutrition, endocrine and metabolic disorders, hypoxia, anemia, malignant disease, and immunosuppression. While in local factors we are having necrotic tissues, excessive use of electrocautery, foreign body, excess of braided non-absorbable suture, hematoma formation which provide free HB, that is rich in ferric iron, poor surgical technique, large region of dead space which result in formation of seromas, and microbial contamination, type and virulence of organisms, and antibiotic resistance. These are the local factors, and the modifiable factors are long pre-op stay, inappropriate time, antibiotic prophylaxis, surgical site shaving 1 day before surgery, drains in wounds, tissues damage, blood loss or blood transfusion. These are the modifiable factors. So we have the definition of surgical infection, then the general factors and local factors, and then the modifiable factors. Now what are the types of surgical infection? These are on basis of anatomy and on the basis of infection sites. On the basis of anatomy, first of all we have superficial incisional surgical site infection, that is occur 30 days after surgery, involve only skin or subcutaneous tissue, and purulent discharge, organisms and signs of inflammation are present. While the second one is deep incisional surgical site infection, which is 23%, the superficial is 47%. Okay, deep incisional surgical site infection occur in 30 days to 1 year of implant is present and involve deep soft tissues. The third one is organ specific infection, which is 30%, and it occurs in 30 days to 1 year. Purulent discharge present and organisms are present and abscesses form. So this was the classification on basis of anatomy. Now on basis of infection we have clean surgical site infection, then clean contaminated, which is also known as class 2, then contaminated class 3, and dirty class 4. In class 1 we have the example of herniorrhaphy. In class 2 we have minimal spillage, for example resection anastomosis. In contaminated we have maximum spillage of contents, for example typhoid, perforation and ileum. In dirty class 4 we have pus found at operation site and 40% of infection rate. So this is the classification on the basis of on the basis of infection. Now, what are the treatment options for the surgical site infection? We have first to recognize, that is recognition of surgical site infection. By daily examining the wound site, examine and look for any erythema, discharge or pus. Look for systemic signs of infection and look for leukocytosis. Ultrasound and CT scan are done to identify the amount of site of collection. Okay, what are the treatment options that we have? First of all, if you have wound site under tension and clear evidence of suppuration is positive, so sutures are removed and drain the pus, and wound should be irrigated with saline solution and pus sent for microbiological cultures, and sensitivity and antibiotics are initiated. Broad spectrum antibiotics are given, antimicrobial therapy is provided, pus is drained, intravenous antibiotics in case of severe infection, surgical incision and drainage, and debridement of necrotic tissues. So we have discussed the topic surgical site infection, which is very simple. First, we have discussed the definition, then what are the general factors that are involved. These are the general factors, the local factors, and the modifiable factors. Then we discuss the types. The types are on the basis of anatomy and on the basis of infection risk. On basis of anatomy, we have superficial incisional surgical site infection and deep incisional surgical site infection, and organ specific infection. On the basis of infection, we have four classes. This is clean class 1, the clean contaminated class 2, the third one is contaminated class 3, and the fourth one is the dirty class 4. What are the treatment options? First, you have to classify or recognize the surgical site infection, and then you have to provide the treatment according that. The treatment options are these: antimicrobial therapy, pus drainage, intravenous antibiotics, surgical incision and drainage and debridement of necrotic tissues. These are the specific treatment options that we will provide to the patient of the surgical site infection. Now, coming towards necrotizing fasciitis or cellulitis. Okay, so what is necrotizing fasciitis or cellulitis? We have a scenario which says that we have a male patient increasing swelling and redness around lateral aspect of right ankle for 5 days. On examination, skin is warm, tender on palpation. What are the causes, risk factors, and management options? Okay, so let's define cellulitis. It is a non-suppurative invasive infection of dermis and subcutaneous tissues where all signs of inflammation are expressed: redness, warmth, swelling, tenderness, border well defined in true cellulitis. What are the causes? The most common organisms that cause cellulitis are beta hemolytic streptococci and Streptococcus pyogenes, Staphylococcus, and Clostridium perfringens. Okay, what is cellulitis? It is a non-suppurative invasive infection of dermis and subcutaneous tissues where all signs of inflammation are expressed. Redness is present, warmth and swelling is present, tenderness is present, and the borders are well defined in true cellulitis. What are the causes? The causative organisms are beta hemolytic streptococci and Streptococcus pyogenes, Staphylococcus, and Clostridium perfringens. Now, what are the risk factors of cellulitis? These are wounds, accidents, surgical tattooing, and skin infections, and low resistance of individuals, and diabetes. These are the main factors of cellulitis. What are the management options? First, you have to take the history of the patient. So, ask about the injury and remaining risk factors. Then, examine the patient. Examine affected area, that is inflamed area with redness, warmth, tenderness, swelling. Borders are well defined usually. Pus present or not in cellulitis. Okay. Now, what are the treatment options? First of all, provide the patient management history. Okay, bed rest with elevated legs to reduce the edema of the leg. Then glycerin MCSO4 dressing when reduces edema of affected part. Then appropriate antibiotics, that is injection, crystalline, penicillin 10 legs units, intramuscular or intravenous 6 orally for 5 to 7 days, or cephalosporin. Okay, so this is a small topics. What is cellulitis? So the scenario is present that the clinical features are given that the skin is warm, tender, and palpation, we have a male patient and there is increased swelling and redness along the lateral aspect of right ankle. So what is the definition of the cellulitis? What are the causes? What are the risk factors? And what is the management option? First, you have to take the history, then examine the patient, and then treat the patient. So this is the general management for the cellulitis. Now coming towards the carbuncle. we have to learn in this that what are the treatment and management options, what are the common sites of carbuncle, what are the common causing organisms of carbuncle, and what is the pathogenesis. Okay, so let's define carbuncle. It is an infective gangrene of subcutaneous tissues caused by Staphylococcus aureus, commonly occur in diabetic patient and is usually on side of nape of neck. Okay, this is the common site for the carbuncle, on the side of the nape of the neck. This is the neck, this is the nape of the neck. Okay, what is the pathology? Initial lesion is similar to a boil in form of hair follicle infection with perifolliculitis. Infection results in necrosis of subcutaneous fat, which give rise to multiple abscesses. Abscesses are multiple and have sieve-like openings, cribriform appearance of carbuncle. Okay, this is the definition of carbuncle. And what is the pathology? In the pathology, there is initial lesions which is similar to boil in form of hair follicle and infection with perifolliculitis. Infection results in necrosis of cutaneous fat, which give rise to multiple abscesses. Abscesses are multiple and have sieve-like openings, cribriform appearance of carbuncle. What are the causes of carbuncle? Staph aureus is the main cause. What are the treatment options? The first treatment option is medical, and then we will give the surgical drainage. So in medical, we will improve the general health of the patient and control the diabetes mellitus if present. Then touch of iodine on skin pustule to hasten necrosis so that pus escapes. Then appropriate antibiotics, that is cloxacillin, erythromycin, cephalosporins. If bacteria are resistant, then intravenous vancomycin can be given. Now the surgical drainage is done in late stages with deroofing to release pus. Once the site of infection is healed, it may require skin grafting. Okay, so what is carbuncle? We have studied the definition. Then what is the pathology? Then what are the causes? Then the treatment is provided. The treatment is medical treatment and surgical treatment. In medical treatment, the health is improved, diabetes is controlled, and the necrosis, iodine of touch of iodine is given to the hasten the necrosis, and then appropriate antibiotics and intravenous vancomycin is given. If the carbuncle is in late stages, then the drain is removed, and once the site of infection is healed, it may require skin grafting. Okay, now coming towards tetanus prophylaxis. What are the prophylactic measures against tetanus? These are two main. We have to manage the wound and we have to give the vaccine. Okay, so for the wound management, first of all we have to clean the wound. Has patient complete primary tetanus diphtheria series? Okay, clean the wound and know about the vaccines. If the patient has complete primary tetanus diphtheria series or not. If no, or the patient doesn't know, then administer vaccine today. Instruct patient to complete the series. If yes, he has administered the vaccine, then was most recent dose within past 10 years. If no, if the dose was not in the past 10 years, then the administer vaccine today and complete series per age. If yes and vaccine not needed today, patient should receive next dose after 10 years. If he had already taken the dose of vaccine in the past 10 years, then there is no need to administer the vaccine. Okay, contaminated wound, dirt, feces, saliva, or his patent completed primary tetanus vaccine. Okay, first, how we will do the tetanus prophylaxis? We will first classify the wound, that is, it is a clean wound or contaminated wound. Then we will provide the treatment according to that. Now, if the wound is contaminated, then we have to know that has the patient completed primary tetanus vaccine. If no or unknown, then administer vaccine and tetanus immunoglobulin now. If yes, he has completed primary tetanus vaccine, then was most recent dose within the past 5 years. For contaminated wound, you have to know the history of 5 years. Okay, if no, then administer vaccine today. Patient should receive next dose per age. And if yes, he have received the vaccine dose in the last 5 years, then vaccine is not needed today. Patient should renew next dose after 10 years. Okay, and then what is the immunization status and what are the types of wound, what are the low risk wound and what are the high risk wound? A type of table is present in the book on page number 151. So if you want to study that, then you can go for it. According to me, the important things for tetanus prophylaxis is this one, which I have already discussed, that is we have wound management, and we have first we have to manage the wound, that is if it is a clean wound or a contaminated wound, then we should know that the what is the vaccine status of the patient, and for what is the past 10 years history of the vaccine administration, and then we will prescribe the vaccine or inject the vaccine in the according to the history of the patient. In next session, we will be discussing the skin tumors. Okay, so now coming towards the skin tumors, we have two main types of carcinomas, that is the basal cell carcinoma and the squamous cell carcinoma. Okay. Hmm. What are the most common malignant tissues arised from basal cells of skin occurs on sun exposed area, also called rodent ulcer. Okay, the basal cell carcinoma is the most common malignant tissue, while the squamous cell carcinoma is the second most common malignant tissue. The basal cell carcinoma arises from basal cells of the lungs, while the squamous cell carcinoma arises from the precursor cell layer of the skin. Okay, basal cell carcinoma occurs on sun exposed areas and also called rodent ulcer. The squamous cell carcinoma occur all over the body except mucous membranes. Now, what are the predisposing factors? Intravenous raised fair skin and arsenic based skin ointments are the predisposing factors of basal cell carcinoma. While the squamous cell carcinoma, we have chronic sun damage, sites of prior burns, arsenic exposure, chronic cutaneous inflammation, sites of previous X-ray therapies, and pre-malignant conditions of the skin are predisposing factors of the squamous cell carcinoma. What are the types of basal cell carcinoma? These are the predisposing factors that we have discussed. Okay, what are the basal cell carcinoma types? These are nodules, pigmented, superficial, cystic, and infiltrative, while the squamous cell carcinoma types are according to the type of growth: ulcerative, ulcerative, proliferative, ulceroproliferative, and according to the location, it is on skin, on mucous membrane, and mucocutaneous junction. What are the investigations that are done for the basal cell carcinoma? These are which biopsy or from edge of ulcers. While in the squamous cell carcinoma, which biopsy of edge of ulcer and lymph node biopsy, fine needle aspiration is done. Okay. What is the spread of the basal cell carcinoma? It is locally invasive and rarely in blood, while the spread of squamous carcinoma, it is local and lymphatic blood is involved. Okay, what are the treatment options for the squamous cell carcinoma? We will do the surgical excision and the radiotherapy. While the treatment of squamous cell carcinoma, we will do the treatment of primary tension, that is surgery or radiotherapy, and the treatment of secondary lesions, that is block dissection of regional lymph nodes. Then 30 to 40% of weight and what watches and then give antibiotics, and lymph nodes hard or mobile, then do the biopsy, and if lymph nodes are hard and fixed, then palliative radiotherapy is done. So we have discussed the skin tumors, that is the basal cell carcinoma and squamous cell carcinoma, its definitions and the common site. And then we discussed the predisposing factors of both the carcinomas, then what are the types of basal cell carcinoma and squamous cell carcinoma, then what are the investigations options, and what is the spread of the carcinomas, and then what are the treatment options. We have discussed this. Okay, now coming towards the malignant melanoma. Okay, now coming towards the malignant melanoma. What is it, the diagnosis? What are the investigations? What are the treatment options? What are the signs of malignant changes in navis? And what are the examinations for metastatic spread? What are the factors determining prognosis? And what are the treatment options? Mm, Okay, this is we are having the mole changes shape and size, increase size over last 1 month. It is itchy, color not changed, no family history, mole on black color on back, and it is non-tender and it's slightly irregular. These are the clinical features, or this is the scenario for the case of malignant melanoma. And these are the questions that are asked: that what are the diagnosis, investigations, and treatment? What are the signs of malignant changes? And what are the examinations for metastatic spread? And what are the factors that determine the prognosis? So this is what is malignant melanoma. It is the most common form of skin cancer if diagnosed earlier, still limited to outermost skin, and it is 100% curable. It is the most common, but it is 100% curable. What are the clinical features? We have lentigo maligna, superficial spreading. We have nodular, acral, lentiginous, and anal anotic. These are the clinical features of the malignant melanoma. What are the signs of malignant changes? These are almost unknown before puberty. and the development of malignancy should be suspected if any of the following changes occur. These are the major signs and the minor signs. Glasgow checklist. The major signs are change in size, change in shape, and change in color, while the minor signs are inflammation, crusting, and bleeding, and sensory changes, for example, itchings, and the diameter is greater than 5 mm. If these changes occur, then we should note that the mole is turning towards the malignant melanoma. Now, what are the signs of malignant changes in navies? These are ABCDE rule. First of all, asymmetry will occur, then border irregularity will occur, then color vision and the diameter will be greater than 5 or 6 millimeter, and then evolving changes in size, shape, surface color, shade, itch, and tenderness. Okay, what examination we have to do? First of all, examine the spread, examine groin area for enlarged lymph nodes, then examine regional lymph nodes for metastatic spread, then examine liver, lung for blood metastasis, and rarely bone. These are the examinations. Then what is the TNM staging for the malignant melanoma? We have T1 1 mm, then T1A with ulceration, T1B without ulceration, then T2 is from 1.1 to 2 mm diameter, T2A with ulceration, T2B without ulceration. Then in T3, if it is 2 to 4 mm, then T3A is with ulceration, T3B is without ulceration, then T4 is 4 mm, then T4A with ulceration, T4B without ulceration. Okay, then nodes. In nodes we have n is equal to no nodes, n1 node, n2 to 3 nodes are involved, n3 4 or more. M is metastasis, M1A distance, M1B lung metastasis, and M1C any other distal metastasis. Now stage 0 is I in situ, N0 and M naught. In 1A, T1A, these are the stages of the melanoma. So 1A, 1B, 2A, 2B, 3 and 4. These are the stages in 1A, T1A, N naught, M naught. In stage 1B, we have T1B, N naught, M naught, T2A, N naught, M naught. T, N naught, M, N naught and T2E. These are described here. That what did T2E mean with ulceration? N naught means that there is no nodules involved. M naught means that there is no metastasis. While in the stage 4, we have any T, any N or any M. Okay, so these are the stages. You have to just give a look and you can write it on your own self. What are the investigations? We will do the excisional biopsy, the CT scan or PET scan is done, ultrasound of abdomen is done for liver metastasis, X-rays for bone is done, and chest X-ray for metastasis is done. What is the primary treatment? Surgery is the main modality for the malignant melanoma. Small lesions of 1 mm can be excised under general anesthesia with 1 cm of healthy margin while excising tumor. Lymph nodes, non-sensational lymph nodes biopsy taken. Positive sentinel lymph nodes should proceed to radical lymph node dissection, and in the advanced disease treatment, we have to do the radiotherapy plus chemotherapy and immunotherapy or hormone therapy or symptomatic relief. What is the prognosis? 5-year survival rate and according to the stages, stage 0 is 99.9%, stage 1 89 to 95, stage 2 45 to 79%, stage 3 24 to 70%, and stage 4 87 to 19%. Okay, so what we have discussed a malignant melanoma. Its scenario that mole change its size and shape and increase in size over last 1 month. It is itchy and color is changed. No family history. Mole on is black in color and is on back, and it is not standard and it's slightly irregular. So these are the clinical features in the diagnosis, investigation, treatment, signs of malignant changes in navis, and examination of metastatic spread factors determining prognosis and treatment options. These are asked. So we have the definition of malignant melanoma. Then we have the clinical features and what are the signs of malignant changes. We have major signs and minor signs and signs of malignant changes in navis. We have ABCDE rule. We will check for symmetry, borderline, color vision, diameter and evolving changes. Then we will do the examination. Examination is done for the spread. Then we will stage the malignant melanoma, that is TNM staging. We will check for the tumor, then the nodes and then the metastasis. Then what are the stages? There are mainly the 5 stages, 1 and 1B, 2 and 2B, 3 and 4. Then we will do the investigations. Then the primary treatment is done, then lymph nodes are checked, and advanced disease treatment is done, and the prognosis is checked. In the next session, we will be discussing the post-op pyrexia and the ganglion and the DVT.